wants pain meds.
She just wants pain meds.
She's upset because they discontinued them.
Oh, but he got a urinary retention. Oh, so she's just taking. I hope someone told me that. No one said that to me. Everybody were like, this positional or it's not positional, or maybe it's to the tumor. No one said that she's taking things.
No one was honest with you about her true intentions.
Yeah.
Which one, Rosier?
Mhm.
She's pain seeking?
She's upset because her percocet was discontinued because she has urinary retention and bowel retention. She has a catheter only because of that.
Rosier. Samantha Rosier?
Yeah, and gave her fluids and
The first day
She's
she
the one that
came?
we did that
and she
thing
still
on last
complains
year.
Yeah,
of
the
pain.
first day she came, she said, don't give me anything addictive. I just want a spinal tap.
Did she go to IR?
She said, I want a spinal tap because it gets rid of my pain. I'm
The
going for a
nurses
spinal tap.
told
He
me
was on bedside and she bled.
Yeah, I did it. I was just because she bled a little bit, so I was wondering if you guys to do the IR too. Because I was
So that's what I'm offering today because she's been here for 7 days.
Yeah, she used to be here for years.
And
Okay,
I was
can I
like,
tell you something? The day she came, she had jury duty the next day because she witnessed someone get beaten up.
oh, so you think she's.
No, she told me. And I told her I wouldn't tell anyone. She's like, if I get admitted to hospital, I won't have to go to the jury duty.
I love it.
And her husband said that she has OSA and she has not been using her CPAP for 2 weeks. And she's in pain, but she stays up all night watching vampire movies. She doesn't use her CPAP. And she has a very bad lifestyle. And jury duty. She's like, can I stay for 1 night just to miss my jury duty? And can you give me a piece of paper in the morning to say that
So
I'm
now
in
she doesn't
hospital?
want to go.
And now she doesn't want to
Sama.
go. I don't know what happens in the middle. I remember admitting to him saying, I'm going to discharge you in the morning.
Can you come with me?
I'll
to
come
see
with
her?
you, yeah.
She's gonna talk to Dr. Dixon now, but I don't know what. And then we have to go and tell her, you either get your spinal tap and get out of here.
She's still in
She's still
She
here.
has had
Oh.
10 spinal taps.
Yeah, she loves spinal taps. She loves having spinal taps.
So weird.
Yeah, she's weird.
What about ophthalmology?
Yeah.
Her eye is fine, right? I
No,
sent a
baby.
picture.
Oh, that's just
I sent a picture to people.
really expensive.
It's my latest hobby.
Yeah, I can see that.
You know what happened?
Should I start?
Yeah, you should.
You could. For one more story.
Okay, we went to Dr. Yan.
Oh God. Someone's like, oh no.
Doctor, I got with
The eye
you know
doctor.
the new fundus
Oh,
camera.
no.
We went to Dr. Human tried it, he didn't. Because it's not like you could just do that, and you have to practice.
It's like some skill, yeah.
He didn't want to learn. He just wanted to do it. He said, "Oh, this is too difficult. I don't think our ophthalmology people will like it. Let's go down and meet him now." He goes down and there's Dr. Young, but I've never met him before. I don't know who he
I
is.
like the product.
Yeah. And then Dr. Young is like, "This is Dr. Young. This is our camera." And Dr. Young is like, "Well, how can I tell you if I like it or not if I haven't seen any images from it?" So I said, "Well, I sent them to you this morning." And he's like, "So what does that mean? Am I supposed to have seen them or not?" You got offended. I was so, Anisha, did I come across? I keep asking you. I didn't come across rude, right?
No, it was funny though, because she's like, oh, I sent you pictures, she's like, you say that as if I should have checked my email already, and I was like,
No, he's not that. No, I know
he's
who
funny,
he
he's
is.
like sarcastic,
He's very dry.
Oh,
I know.
dry humor.
Yeah. Please. I don't think I think it's just that he has this kind of flat
It's a
dry
friend.
I don't get it. but-
Different sense of humor.
Yeah.
Yeah.
I thought that he said that he liked it.
No, he said I don't know anything about it. So I was like, well, you can keep it and let us know.
I know it is possible.
Should we start? I think some of you already saw this last year. I just made a couple of changes. So we're going to talk about acute spinal cord injury. And I don't know who was with me in the neuro ICU last year when I saw this case. I want to say Saman, but I'm not sure. This is a 67-year-old man that presented with sudden onset of bilateral leg swelling, perineal numbness, legs weakness, transient hypotension, diaphoresis, and tachypnea. And so he got 2 liters nasal normal saline bolus in ED, and all these transient symptoms resolved. And he got a chest CTA because they wanted to rule out dissection. And we found an IVC thrombus in an IVC filter that he had placed and some segmental PEs. But after they resuscitated him and his blood pressure was stable and his exam was still significant for bilateral lower extremity weakness, unable to raise off the bed as per the ED resident, and perineal numbness. So what else would you like to know? If you're on the phone and you're saying 1 million consults and you want to make sure you don't have to see this patient right now. You want to know reflected?
A level, spinal level? Like numbness.
They said perineal.
Okay. Rectal tone.
Yes. They want to know if the rectal tone is normal. And what else that comes with rectal tone? Bowel or bladder incontinence, right? Which can be the transient hypotension doesn't really fix, right, with cauda because you don't get that unless you are high cervical from a spinal cord injury. But we know he had these PEs, so maybe he threw these PEs and he was hypotensive because of this. But at the same time, he may have some sort of cauda. So in the review systems, probably have some type of subjective fevers 1 week ago with right foot pain. But he lifted his neighbor up the floor 2 days prior presentation. He has a medical history pertinent for hypertension, colon cancer in 2005 that actually was treated, and he said that he was on remission, and he had a prostatectomy 1 month ago for prostate cancer. Why is that important? Yeah, he can get hypercoagulable, but also because that can go into the vertebral and make him more prone to have spinal cord injuries secondary to herniated nucleus pulposus, or he can get some sort of epidural mass. His medications only BP meds. And his labs, he has some leukocytosis, anemia, mild thrombocytopenia, and we don't know if it's an AKI versus a CKD. Anybody see something? This is MRI. This is sagittal T1 flare and sagittal T2.
Between L2 and L3.
So if you didn't have these numbers, let's just focus on this one. You always want to look and identify the sacrum. And obviously above the sacrum, you're going to have L5. So you can start counting L5, L4, L3, L2. And this got my attention. First time I saw it, I was like, there's something sequestered there. I know. Looks like all these fibers, the cytokine are sequestered with the CSF surrounding it. And in the T2, you can tell that this disc and this disc don't look as healthy and as these other discs. And you can see that they are rounded and they have a full height. And in addition to that, you have this herniated disc in this area. So basically, I just wanted to tell you how complicated a patient can be, and that you cannot say just because they have a PE, oh, okay, whatever is a PE. No, he also had something real.
Maybe this caused his PE. this happened, he became immobile.
No, he 2 days ago.
Okay.
Yeah, he will tell you 2 days ago he felt when he herniated his disc when he tried to pull his neighbor up, and but seems like he already had DVTs in his lower extremities, and he just threw the piece, and that's what brought him to the hospital. And actually, he was in the ICU. We started anticoagulation, and he also had ITP, so he was started on steroids, and his weakness actually improved, so he didn't need intervention. Any questions with that? So this is a very general neuroanatomy. These are the vertebrae. We know that there are 8 cervical nerves because they go below the vertebrae. And so we have 7 vertebrae but 8 cervical nerves. And in general, your cervical nerves help you to breathe and arms strength, except the spreading of the fingers or the abduction and of the fingers, that is part of the thoracic. And in the thoracic, you have your chest muscles, your abdominal muscles, your back muscles. Also, you have the intermediolateral cell columns that are for preganglionic sympathetic neurons. And in the lumbar, we always think about hip and below. And then the sacrum is bladder, bowel, and sexual function. And then these are the dermatomes that if you are very good and you have this visual and photographic memory, you can just memorize them. And for me, it's important that you remember that the back of your head is cervical. It's not V1 to V3 because it's a very common mistake. And patients comes with headaches that come and radiate into the back of their head. And yeah, you can think about occipital neuralgias, but you also have to think about their spine disease that may be also radiating into the head and causing this type of headaches. And T4 are the nipples, and T10 is the umbilicus, and then sacrum is in the genitals and in the back of the legs, and then you have this pattern of kind of an oblique form of L1, L2, L3, L4, L5, and at the end you have a little bit of S4 that comes from the back, and in the soul is L5. So this is a transverse plane. Can someone tell me which level is this? How do you know?
Because the brain to wide matter as much.
That's one of the ways to know. It's the biggest segment, but there is something that someone mentioned that is even easier.
Oh, I know. The posterior column.
The posterior columns, you have the fasciculus cuneatus there, and only on the cervical part of your spinal cord you will have that because that's proprioception and vibration from your upper extremities. And I always remember being like this. So cuneatus is the outside, the arms, and gracilis is the midline, it's the legs. So these are the posterior columns, and in this side of the slide, we are looking at the ascending tracts that mostly are sensory, means that they are coming from the periphery all the way up into the brain. And pertinent clinical ones are the fasciculus gracilis and cuneatus, that we know that is ipsilateral proprioception and vibration, and the lateral spinothalamic, that is contralateral pain and temperature. Right, every time you get a fiber and to the spinothalamic with pain and temperature information, it ascends 1 or 2 levels and then decussates right away into the anterior commissure and goes to the contralateral ventroposterolateral thalamus. In this side of this slide, you have the descending tracts. So I always think about cortex to the spine, so go down. And again, the most pertinent is the lateral corticospinal tract. We know that it's ipsilateral motor strength And basically, this, that decusates in the caudal medulla, basically goes ipsilateral in the cortex, in the centrum senio valley, and then corona radiata, all the way down until the medulla decusates, and then it runs ipsilateral into the spinal cord. And the ventral corticospinal tracts may be a little bit pertinent clinically because sometimes we cannot understand why our patient has contralateral weakness. And it's because this one never decusates into the pyramids. So you can have contralateral weakness from damaging the spinal cord. And then all these spinal, reticulospinal, spinocerebellar, they are important. We are not really clear in details in the humans, but it has to do with positioning and maintaining your balance every time you hear some noise or you get scared, and how you change your position and you don't fall. And then this is what Annie actually was mentioning. So from the cervical area into the sacrum area, the biggest and largest portion is in the cervical slide. And then as you go to the thorax, you start seeing like the fibers are smaller. It looks kind of like anorexic. I remember one of my attendants, we would call it becomes anorexic. And then you have like a larger portion of the sacrum into you just have gray matter and no white matter in the conus medullaris. The muscle grading 0 to 5, basically 0 is paralysis, palpate or see some contractions. 2 is basically they can move side to side. 3 is anti-gravity, but cannot provide resistance. And then after 4, you can see the 4 minus, the 4 plus, okay, and confusing. And depending if they can provide some resistance or resistance. And then 5 should be just normal and provides normal resistance. Some people call 5 minus, but you don't know what is 5 minus versus 4 plus. So usually we don't recommend to use those minus or plus in the 5, only on the 4. And then non-testable is like the patient has pain or is amputated. And then this is a review of the blood supply. You have only one anterior spinal artery, and that covers and supplies the anterior 2/3 of the spinal cord. And this comes from the vertebral arteries. They basically unify in only one artery on the front of the spinal cord, on the anterior part or ventral part of the spinal cord. And then the vertebral arteries also supply 2 posterior spinal arteries. And you can have some supply from the radicular arteries coming from the intercostals and coming also from branches of the aorta. And those helps to the watershed areas between the ASA and PSA. And then this is just to remind you the artery of Adam Kiewicz, and that if you have a patient that became acutely paraplegic after some sort of abdominal surgery, you have to consider that this patient may be having a watershed stroke, because this is a very large branch of the radicular artery from the thoracic aorta coming and supplying part and helping the anterior spinal artery. Clinical syndromes. So obviously paraplegia, and we have to also tell our colleagues it is complete or incomplete. Complete means that you have no motor, no sensory, no sacral segments, so involvement of bladder and bowel function below the level of the lesion. Incomplete means that you may have some sensory preservation or some motor preservation, and most of the time this is referred also that the patient may have bowel and bladder function. Tetraplegia is the same, it's just like it's a cervical lesion. And again, it is complete, means that you have no sensory, no motor function, no sacral functions. Incomplete is that you may have some motor, some sensory, depending on the level and the type of lesion. And usually you have preservation of your sphincters. So common types of incomplete spinal cord injury and the Brown Sequard. Can someone tell me? Yes, you have them. What are you gonna expect for Brown Sequard syndrome?
So you'll see the level of the injury was the ipsilateral level of sensory was lost, the overvalue. But then if the contralateral below 2 levels down will be the pen temperature loss.
Okay.
And then the ipsilateral corticospinal.
Okay. Central cord syndrome, usually these are syringomyelia, or actually Brown Sequard is one of the most common syndromes when you are having trauma or transection to the cord. And central cord syndrome is usually syringomyelia, and that can be congenital and can be post-traumatic. Ependymomas and intramedullary tumors can also cause this type of syndromes. And then here you will involve bilateral anterior horns. So you are going to have weakness mostly in the level that you're affecting, and it's flaccid paralysis. And you also have bilateral loss of pain and temperature because your anterior commissure is affecting those spinothalamic tracts. The posterior spinal cord syndrome, do you know what can cause you this? Syphilis. Yeah. If you involve the corticospinals, also V12, so that can combine coordination. And basically, if it's only the posterior part, loss of proprioception and vibration bilaterally. This is also true if you're having spinal cord stroke involving the posterior spinal arteries. For syndromes, usually is involvement of the anterior sternal artery, and in this case, you will have basically as if it's a complete damage. You involve your bilateral corticospinals, you involve your bilateral spinothalamics. The only thing that you're going to have to serve is your vibration and your proprioception. So we usually don't test for that, but this is the importance of why you have to do all those modalities. And actually for pain and temperature, I think an ice pack is the easiest way to really what is the level of the sensory problem. Okay, Asia impairment scale, and this is something that we are trying to teach, that every time you see a patient with an acute spinal cord injury, you should document. And the lowest is the worst. So an Asia A is basically the complete transection, is a complete spinal cord injury. And basically below the lesion, you have no motor, no sensory, no sacral segments. And then B will be incomplete, only sparing the sensory, but you have motor involvement and you have sacral segments involvement. And C is incomplete, but you have some motor preservation. It's just like the key muscles, usually the anti-gravity muscles, are less than 3 in the power. And Asia B is incomplete. And in this case, you have motor preservation and your key muscles are more than 3. And Asia E is normal. So what can cause acute spinal cord injury? So the most common cause is trauma, cervical, more than lumbar, more than thoracic, because are the most movable joints. Falls are definitely the main cause, especially in these days. More than motor vehicle accident, more than firearm or penetrating injuries. Neoplastic metastatic is the most common, and usually are extradural lesions, and these involve mostly thoracic more than lumbosacral, more than cervical, and lung, breast, prostate, lymphoma, and renal cell carcinoma are the most common tumors that metastasize to the spine. If you're talking about primary neoplasms, it's less than 10% of the cases. Multiple myeloma, chordomas, Ewing sarcomas, chondrosarcomas, and osteogenic sarcomas are the most common. If it's an intradural extramedullary lesion, you have to think about meningiomas or nerve sheath tumors. If it's intramedullary, then you have to think about ependymomas or astrocytomas. And infectious etiologies, epidural abscesses are very rare, but when you see them, you'll never forget about them because they are very complicated to treat and have a very high mortality. Up to 30% of the patients die. And usually, elderly immunocompromised patients are the ones that you have to suspect. They come with neck pain, low back pain, fevers, leukocytosis. You have to have a very high suspicion because sometimes they just come with pain, not any signs of weakness. And diabetic patients, intravenous drugs abuse. If your patient has surgery or any procedure, so if they are getting epidural injections for pain, you have to suspect it. And anyone with chronic renal failure, alcoholism, cancers, or HIV. And then you can have, you mentioned anything, but the most common is Staphylococcus aureus, basically MSSA. Unless your patient had a surgery or a procedure or an injection, then you have to think more about gram-negative organisms. But if you suspect it and you find that, you just want to treat everything unless you have a pathology, I'm sorry, a microbiology pointing you to the exact organism with sensitivities. Another etiologies that are not that common, but you always have to have in the back of your mind are vascular malformations, coagulopathies, and let's see, spinal tumors with radiotherapy that can also induce telangiectasias and cause bleed. And our non-compressive myelopathies that we see in our neurology floor most of the time, we have the serogomyelia, again, it could be secondary to trauma or just congenital. And the inflammatory myelitis, we have multiple sclerosis, now more recognized and neuromyelitis optica, and sometimes just post-infectious, viruses can cause also inflammatory myelitis. And so just talking a little bit about the pathophysiology of the spinal cord injury is the same principle of the primary injury causes these action sheets to just transect, and this causes a whole different cascade of inflammation, lipid peroxidation, just comes, glutamate comes, calcium comes, and all this causes swelling that eventually are gonna promote lesions and encephalomalacia that are going to prevent for your spinal cord to recover. And that's why spinal cord injuries usually don't do very well and they're very disable in the long term because those cystic lesions are preventing from those axons and myelin to actually try to go around the injury or try to restore all that function that was lost. And this is why we are trying stem cells. Some people are trying monoclonal antibodies. Still, everything is very experimental. So how to diagnose your spinal cord injury? Always careful history, physical exam. If you are suspecting infection, if there is any systemic involvement, or if your patient has an INR of 10. And imaging should always be oriented to begin at least 2 spinal segments above your suspected injury and all the way down to the conus. And contrast gadolinium administration if you think that your patient may have a neoplasm or an infection and or an inflammatory disease. If not, if it's trauma, you don't need to use gadolinium. MRI is the gold standard unless your patient is stable or has a contraindication, and then CT. And still, some people ask for CT myelograms when contraindications for MRI are found. And but I have found that most of the radiologists don't do CT myelograms anymore. There's a lot of complications and cause contrast-induced meningitis, and they just avoid going to that step. They would rather call the cardiologist and make sure that if it's secondary to pacemaker, they can monitor the patient and maybe restart the pacemaker if there is any problems during the imaging, but otherwise they will not pursue the CT myelogram. But this is what the book says. So treatment, the most important, as always, ABC. Make sure your patient is breathing and doesn't need intubation. And so forced vital capacity, we always say it has to be greater than 15 mLs per kilograms, and a NEAF has to be greater than -20, meaning more negative than -20. If that's not the case, then you have to consider intubation. The lower ASHE scores and the more rostral injuries are the ones that usually go into acute respiratory failure, are the ones that you have to consider early tracheostomies, and they actually they are very challenging from the mechanical ventilation, not only because of the weakness and that they involve the diaphragm and if they are above support, also because if they are rostral and in the cervical area, you have the transection from the sympathetic autonomic system, and you basically have an unopposed beta stimuli that will cause also bronchial mucus hypersecretion. That is weak, that cannot breathe, and is having a lot of secretion. So that's just a recipe for disaster. And when you intubate them, you are always going to do full ventilation support with assistant control or pressure control. And this population, we recommend a higher tidal volume. We always say like 6 to 8 in normal patients, but these patients cannot even expand their thorax. So usually you can go up to 12 mLs per kilograms in tidal volume, as long as your plateau pressures and your peak pressures are adequate. And always consider having a higher PEEP of 7 to prevent that bivascular atelectasis that can also be complicated with pneumonia. And the weaning is very, very challenging, and the most common way of weaning these patients, and they say it's the most successful, and it's progressive ventilation-free breathing. And basically you disconnect the patient for 5 minutes, you reconnect. In the next hour, disconnect the patient for 10 minutes, and then reconnect to the ventilator. And so on. As the patient is tolerating, you do more free ventilation time, and until the patient is weaned completely. I never saw it working, to be honest with you. We tried it with 2 patients and they failed. And one of the other common weaning methods is the pressure support ventilation. And basically you do very high pressure support, like at least 20, and then you go and decrease the pressure support. But this patient has to be able to get and ventilate and try to move all that tidal volume that he needs for ventilation. So it's tricky too. The one that I found that was the most useful was SIMV, and it's a combined method that you basically are going to support an established number of breaths with the established tidal volume, and then you're going to let your patient do extra breathe with whatever type of volume he feels comfortable with, and you just decrease the respiratory rate every day. So there are more and more breaths that your patient are doing by themselves, And these patients get very, very anxious when you try to disconnect them from the ventilator. So this helps with the anxiety that they feel that the ventilator is there, even when they are doing most of the work, of the breathing work. So I will say like most of our acute spinal cord injuries, we will go with the SIMV ventilation and weaning protocol. If your patient is hemodynamically unstable, you have to consider internal bleeding. If it's a trauma patient, usually these are tachycardic. If they're hypotensive and tachycardic, consider a MAN scan or a bedside fast ultrasound. And versus if they have a neurogenic shock, they're usually hypotensive and bradycardic. So that's something to have in the back of your mind. And among the things that we want to do to treat our spinal cord injuries to maintain perfusion is having a MAP greater than 85 to 90 for at least the first 7 days after the injury. It's level B, not very strong recommendation, but we don't have much to treat our patients, so we do it. Some patients, some neurosurgeons or orthopedic surgeons don't like this because they really think that actually you are hypoperfusing the patient and that this can aggravate the edema and the secondary injury in the spinal cord. But I would say like 90% of your surgeons are going to go for the MAP greater than 90% of this. What vasopressors do you use when your patient is not meeting that criteria of MAP greater than 90 or are going into a spinal shock? And so the agent of choice is actually dopamine. And a lot of people say, no, dopamine will make your patient tachycardic, but these patients, remember, have no sympathetic input, basically, for at least 24, 48, even to up to 72 hours. So dopamine will give you that benefit of the inotropic effect with the vasoconstriction effect. And usually these patients tolerate it very well. You don't need a central line. You can do it peripherally and only for 7 days. So it's actually the agent of choice. And I would say every time we use it, I don't remember one patient that didn't tolerate it. And if your patients get very tachycardic or your neurosurgeon doesn't like the dopamine, that can happen. Then the second choice is Levophed, followed by phenylephrine, followed by epinephrine, and the last one will be dobutamine, but this will be more like a combination with other vasoconstrictor. You will never use dobutamine alone, specifically in acute spinal cord injury.
What about the hypothermia in spinal?
Yes. So University of Miami, if you are talking, talking about treatments, and if you have a patient that has a traumatic spinal cord injury, if it's an unstable cervical fracture, the STASIS study in 2012, which is one of the strongest, largest studies done in traumatic cervical spinal cord injury, recommends decompression and fixation, ideally within 24 hours after the trauma. And they actually found that your patients will improve at least 2 ASIA scores in 6 months. And if your patient is not stable enough, you can just bring the patient for decompression, bring the patient out of the OR, stabilize your patient, and when the patient is more stable, you can bring him back for the fixation. They always should have a fixation, even if it's delayed, because if not, you are going to have hyperlordosis or kyphosis because your bones are not stabilized. And methylprednisolone is a big no. There is no, like, all the studies that have been done show that you have more complications than benefits. So you should never do it in trauma. And then hypothermia, the University of Miami and in Jackson Memorial Hospital specifically And they did this big study in 2010, and they said that it's safe, that it doesn't increase the rates of pneumonia or DVTs or any other type of complications. You will, as soon as your patient comes to the intensive care unit, you will do a target temperature of 33 degrees for 48 hours post-injury. And they said that 42 to 43% of the patients recover from complete to incomplete injury. And this is basically an attempt to decrease that secondary injury that you have after the primary injury. And a lot of people say that you are going to improve from complete to incomplete eventually, no matter what. And so not many people believe this data, but we are still doing it. And they still say that it's safe. They still are recollecting data because they are very big believers into the hypothermia after the spinal cord injury. And actually, the Miami project is one of the biggest projects for after 3 to 6 months. These patients that were cold are injected stem cells, and we are still waiting for those results. So it's safe. That's all we can say.
Why would they say they improve
Hmm?
hypothermia? Why would they say they improve hypothermia?
Why did they say it's the data. The patients that came with complete spinal cord injury, they noticed that after being in the hypothermia, they improved to incomplete. So to prevent the secondary injury, all that inflammatory pathway for glutamate and calcium and edema, that will help and less encephalomalacia, basically. And so the metastatic spinal cord injury or compressions is to either decompress with surgical resection followed by radiotherapy, or to do only palliative radiotherapy, depending on your patient, your surgeon, how aggressive your surgeon wants to be. And in this case, definitely methylprednisolone has improved vasogenic edema. You have to have in the back of your mind that if you have a diabetic patient, the blood sugar is going to get on control and all the other complications that come with steroids. And with the pleural spinal abscesses, the recommendation and the strongest recommendation, especially after 2013, is that you should do early surgical intervention to evacuate that abscess. Obviously, you will send that to microbiology, and also IV antibiotic therapy for at least 4 to 6 weeks. Unless you have osteomyelitis, you give at least 8 weeks. And if you have a small abscess, there are some surgeons that are going to tell you, let's do aggressive antibiotics and let's repeat the imaging. And I had those cases, and they have improved and come back to baseline too. So it's really hard and complicated to decide who should go to early versus late and surgical intervention. But my opinion is like, if your patient has lower motor scores and is becoming paraplegic, and you should be more aggressive and do early versus delay surgical intervention.
If a patient already has a lesion, let's say in trauma, you still take them to the for fixation in the compression in the acute setting still.
Yes.
And when we're talking about inflammation, the size of, let's say, the epidural, is there any like guideline for the size, or we go for like the clinical presentation and how the patient is doing and the correlation with
So the recommendations is to do early surgery and IV antibiotics, no matter what size the epidural abscess is. And but I've seen that surgeons just sit on it if it's small, or if the patient is too unstable because it's septic, they just try to wait and see if the patient improves. And if the patient improves, they would just say, Let's try the antibiotics, and if the MRI shows that the epidural abscess is not decreasing in size, then they do surgery. So any hemorrhages, obviously you want to reverse the coagulopathy or the thrombocytopenia and decompress. Usually these are disasters. And inflammatory myelitis, and we use methylprednisolone, an antibiotic if it's infectious. And then remember, it's not only treating the spinal cord lesion. If you're having a patient that is having involvement of the sacral nerves or the sphincter functions, 85% of these patients will have some sort of bladder dysfunction, either spastic, that they kind of like pee now and then, but never empty the bladder completely, or flaccid, that basically they're always dripping and peeing on themselves. And so every time you have these patients, you have to check a postcoital residual, because they can look normal, but they are not really normal and they are retaining. And consider intermittent catheterizations. And long term, we always recommend pharmacotherapy with antimuscarinics, alpha 1 and 2 agonists, benzos, GABA B agonists, or even Botox into the detrusor muscle. And surgery and neuromodulation are more extreme interventions that can also be done. And these patients in the gastrointestinal system, they basically don't move, right? So they get ileus. Plus, we also give them pain medications because they are in pain, and they can have fecal impactions because of the pain and the stress. They get peptic ulcers and pancreatitis. And pancreatitis is something that we don't think about, but if your patient has fevers and a white count and you cannot find any reason, you should look for the lipase level. And so everybody needs bowel regimens, PPI or H2 blocker. And also something very important is that these patients, if it's post-trauma, they can be hypermetabolic, and you can start giving them like the usual high caloric nutrition. But as they become subacute to chronic, they start to go into hypermetabolic state because they don't move. So you have to consider that in your nutrition and make sure that you are not overfeeding them, making them obese, and also provoking them to have problems with breathing because they are going to have excess of CO2 when you are giving them too much nutrition. In the heme system, DVT prophylaxis, we prefer the lower molecular weight heparin or Lovenox. If the patient is greater than 60 kilos, we go for the 30 subQ Q12. If it's less, we do the 40 subQ Q12. And you want to start the pharmacological prophylaxis as soon as possible, at least 72 hours post-injury. And if your surgeon feels comfortable, we actually try to do 24 hours after surgery, if possible. And now they were using Eliquis even for DVT prophylaxis on these high risk patients, especially the patients that also have any long bone fractures and get DVT more frequently. And it's very controversial, but some surgeons like to do prophylaxis IVC filter if there is any contraindication for chemical DVT prophylaxis. And I would say that it's very rare that a surgeon would like to do that, but I've seen it, especially if your patient has GI bleeds or they are concerned about a pelvic fracture, that they do not like to do any type of chemical DVT prophylaxis because they are concerned about bleeding. But the DVT rate is actually as high as 100% in these patients. So it's something that you have to be aware of. And then the last system that we're going to talk about, and with this I am finishing, and is skin, and it's to prevent pressure ulcers. Obviously, you want to turn your patient every 2 hours. and if you develop, then you do medical or surgical treatment depending on the stage. This is just to remind you the pressure ulcer stages that we don't think about it because usually the nurses are the ones who are always aware of this. Stage 1 is just the blanching. You have an intact skin. Stage 2, you already have partial thickness of the even of the dermis is lost. Stage 3, you start seeing like full thickness tissue loss, but you don't see muscle or tendons or bones. If you start seeing those, then it's the stage 4, and then it's stage 4. That's it. Any questions?
How did Ravinez do? The lady with the dual access.
They made her complicated. Yeah, she was the problem with her is that we always wanted to give her cefepime, and then the infectious disease. They insisted, and then they put her on ceftriaxone. And when she was transferred to the floor, she started having CSF leaks.
Oh.
So they did several repairs in the dura that didn't work, and then they put her on a PCA pump, and she couldn't even talk. Became very delirious, and the daughter was like, this is not going anywhere, and she doesn't want this. So she was very complicated.
She got better in the beginning.
Yeah, I always think if we would insist in the cefepime, things were different, but you never know, right? There you go. Take some brains.
Yeah. 67588. It's not easy, right?
That's the door. Someone I saw one face.
Yeah.
So
How was today?
facial twitch and